Hi all, so let's learn about ventouse delivery today. A ventouse or vacuum assisted delivery is a form of assisted vaginal delivery that uses a suction cup. It offers a safe and effective option for delivery in second stage of labor when indicated.
Types of vacuum. Ventouse cups are either soft or rigid instruments depending on the material from which they are made. The Malmstrom cup. This is a rigid metal cup. Usually, this would have a central traction chain and a separate vacuum cup. They come in a range of sizes between 4 and 6 cm in diameter. Greater traction forces may be obtained with the metal cup provided they have been placed correctly. These cups are therefore more appropriate for mid-cavity deliveries, particularly if there is a moderate amount of caput, a large fetus, a deflexed fetal position, and/or poor maternal effort. The plastic or the celastic cup. Plastic or celastic cups are more pliable and therefore easier to insert. They are generally a standard size, reusable, must be sterilized between patients. The suction tube also acts as the traction handle. The celastic cups do not adhere well when there is significant caput that is present. As traction is delivered through the suction tube, in the absence of a good seal, limited traction can be achieved. They are therefore more suitable for outlet deliveries or those with minimal caput. The Kiwi cup. The Kiwi cup was introduced as an alternative. This is a fully disposable product in which the suction is created manually without the need for a separate pump. Both an OP and a standard cup are available. Coming to prerequisites. On examination, that is abdominal and vaginal examination, ensure that the head is less than equal to 1/5 palpable per abdomen. Cervix is fully dilated and the membranes ruptured. Station is at the level of the ischial spines or below. Position of the fetal head has to be determined. Caput and molding is no more than moderate. Pelvis is deemed adequate. Preparation of the mother. Clear explanation should be given and informed consent should be taken and documented in women's notes. Trust established and full cooperation sought. Maternal bladder should be empty. Appropriate analgesia should be in place. Indwelling catheter has been removed or balloon has to be deflated. Aseptic technique followed. Preparation of staff. Operator has the knowledge, experience, and skill necessary. Adequate facilities are available: equipment, bed, lighting, and access to an operation theatre. A backup plan is available in case of failure. Anticipation of complications that may arise. Personnel present who are trained in neonatal resuscitation. For consent, for birth room procedures, verbal consent should be obtained prior to assisted vaginal birth. For mid-pelvic or rotational birth, in case shifting to the theatre is indicated, a written consent should be taken. Coming to vacuum application at the flexion point. Flexion point is 3 cm in front of the posterior fontanelle. Traction from the flexion point flexes the fetal head to the narrowest suboccipito-pragmatic diameter, which is 9.5 cm. Most cups are 5 to 6 cm in diameter, so if the cup is applied, the rear edge is at the posterior fontanelle, then the center of the cup is at the flexion point. For application, first follow the prerequisites, confirm the examination findings, and then insert the vacuum cup sideways onto the flexion point. Apply over the flexing medium. To avoid asynclitism, the cup should be applied over the central sagittal suture. Vacuum is then created to about 0.2 kg per centimeter and ensure no maternal tissue has been included in this manner by sweeping one finger all around it. If all is clear, the pressure is further increased to 0.8 kg per centimeter. The force is then applied perpendicular to the handle and downward to maintain flexion and in direction of the pelvic axis, but not more than 15 minutes. The baby is then delivered by the Ridson maneuver after detaching the vacuum cup, and the subsequent steps are the same as any vaginal delivery. When to abandon the procedure. Discontinue vacuum assisted birth where there is no evidence of progressive descent, with moderate traction during each pull of a correctly applied instrument by an experienced operator. Complete vacuum assisted birth in the majority of cases with a maximum of 3 pulls to bring the fetal head onto the perineum. 3 additional gentle pulls can be used to ease the head out of the perineum. If there is minimal descent with the first 2 pulls of a vacuum, the operator should consider whether the application is suboptimal, the fetal position has been incorrectly diagnosed, or there is cephalopelvic disproportion. Discontinue vacuum assisted birth if there have been 2 pop offs of the instrument.
Thus, vacuum delivery provides us a safe and a relatively easy option, facilitating delivery in second stage of labor as long as the basic principles of vacuum application are fulfilled.